Good morning, everyone. I hope all of you are having a great Friday today. Thank you for joining us at the CQC team for today's webinar on billing for telehealth and virtual care. We're delighted all of you are here to join us today, especially as we know this issue has been especially challenging for small practices and IPAs. As a reminder, this session is being recorded and will be available to you 1 to 2 days after the webinar is complete. I want you to please pay attention to the chat as we are sharing right now a PDF of the slides for you to download so you can follow along. However, these slides, the recording, as well as the URLs mentioned, will be sent via email to registrants after today's webinar. So before we get started, here are a couple Zoom tips for you to review. If you would like to speak during the Q&A session, you can mute yourself. If you have joined through a computer, you will have a microphone and you can click to mute or unmute yourself. If you have joined by phone, just press *6 or click the phone icon to mute or mute yourself. If you have any questions or comments, please utilize the chat box through the webinar, and we'll moderate and answer as best as we can. If you have any technical issues, please direct your messages to me, Jose Ordóñez, and I will do my best to assist you. I would like to also go through a few Zoom polls tips. When we have a poll, a screen will appear, a pop-up screen will appear. Please select your answer, click submit, and that pop-up window will disappear. And that's how you know that your answer will be recorded. At this moment, I would like to ask everyone to chat their name and organization. And as we're finishing this, I would like to start with our first polls of the days. We would like to know from where are you dialing, and also what type of organizations are you part of. Starting to see that there's a lot of people joining from the Bay Area. And also we have an audience of providers, IPAs. We have some people from some nonprofits. I'll give you 15 seconds more to finish these polls. Okay. So we have a lot of people from the Bay Area today. Thank you for joining us. And a lot of people from IPAs as well too. So CQC has been providing support for the small provider community over the past several weeks. We hope you can join us for our next webinar session, which will be on Friday, May 29, from 12 to 1, and this will be a topic on patient engagement in virtual care. Also, you may access the CQC's COVID-19 resource page, which is updated at least weekly, which includes resources and provides like telehealth implementation, billing, and any other resources. Michael from the CQC team right now will put both links into the chat. And at this point, I would like to hand the stage to Chris Yeager.
Good afternoon, everyone. I'm Chris Yeager, the Vice President of Care Redesign for CQC. Thank you for joining us today. I'll let you read the slide about the real background of CQC, but at a high level, we're a healthcare improvement organization that serves the state of California to improve quality and efficiency of care. Today, our role is one of convener and facilitator for the identification of best practices. Next slide, please. I'll let you read the objectives to yourselves. Note that we'll be covering outpatient billing today, not FQHC inpatient or SNF billing. And we've been having these learning webinars for small practices and IPA since late March, providing opportunities for both peers and experts to share expertise around telehealth implementation. And providers have been doing amazing work adopting and offering virtual care in a short time. But billing remains a challenge, and that limits how telehealth may be adopted today and in the future. So hopefully this webinar will help address some of your issues. And lastly, I'd like to recognize that billing challenges can be incredibly specific to each practice. So if we can't answer your question today, we'll do our best to follow up on unanswered questions after the webinar. Next slide, please. So we'd like you to chat in how are billing concerns impacting provisions of healthcare. I'll let you have a few moments to do that. Absolutely, providers worried about getting paid. Claims going out, but are we getting reimbursed? Absolutely, revenue decreases with transition from face-to-face to telehealth visits in the midst of the crisis, ongoing changing guidelines. Well, hopefully we'll be able to address some of that for you today during the webinar. Denials, of course. Next slide, please. Before we leap into the core of our content, I'd like to just do a couple of polls with you quickly. The first one relates to what degree are you starting to increase face-to-face visits from telehealth visits? And just an estimate would be wonderful. Patients don't want to come in. Yes, we've been hearing that.
Please make sure to click that submit button so your answer is recorded.
So it looks like a range here from not yet to 75%, but 60% at 40% or lower, or 25% or lower. So still predominantly telehealth. Thank you. One more poll, please, before we get into the core. Regarding small business administration loans, paycheck protection program loans, or other types of financial support, how has your organization been addressing those? Have you applied and received funds, applied and waiting, applied and have been declined, not applied but are considering applying, or do not intend to apply? We'll wrap this one up in a moment. So 2/3 not intend to apply. Thank you. Okay, let's move on to the next slide, please. So at the time of registration, we asked for feedback regarding what type of communication you received from health plans regarding claims. And greater than 80% had not received any feedback. Some respondents noted no problems in getting paid, while others commented on problems with TPAs and rejection for billing for telephonic visits. Chat in if this is different from your organization experience. And while you're doing that, we'll move to the next slide. We just added as a reference for you. This is a resource from the IHA. It was compiled on March 30th, as noted at the top. And we certainly won't go into any detail at the moment on this. We wanted to include this as a resource for you, knowing that some of this has changed. I'm sure our guest speakers will cover some of those changes during their part of the webinar. Okay, why don't we move into the next slide, please?
Chris, this is really quickly, this is Lance. That was too much information to read quickly.
Oh, absolutely.
In your reading it, did you find that plans are following DMHC instruction about coding and creating a consistent approach, or are they varying all over the place?
In general, I think they're following the DMHC and Department of Insurance guidance. I think the variability especially exists still on the ERISA self-insured plan space. I think our guest speakers can get in some of the variation across the plans when we get to that part. You're absolutely right, Lance. It's a lot of information. We included mostly as a resource for after the webinar so people could look at it in detail.
But the key thing is that there is instruction from DOI and DMHC that the plan should be following to reduce confusion.
That's right. Thanks, Lance. So it's my pleasure to introduce our two guests for today. Each of our speakers will have some time to share their knowledge and perspective, and then we'll have some time for Q&A at the end. Carol Yarbrough is a healthcare compliance and reimbursement specialist at UCSF. She has a unique background in legal, technology, revenue management, clinic management, and both federal and state regulations. For the past 4 years, she's been actively contributed to telehealth initiatives at UC Health, working hands-on with professional fee and hospital-based fee professionals to implement billing strategies and provide real-time feedback to clinicians regarding documentation and staff with encounter guidance. She also trains to the CPT coding professionals at the UC Medical Center in order to maximize EMR workflow with greater documentation and coding understanding. And Dr. Subash is completing her rheumatology and clinical informatics fellowships at UCSF. In addition to her clinical background, she leverages her previous experiences in quality improvement, user experience and user interface, and data analytics to support the Telehealth Resource Center at UCSF, playing a unique role as the bridge between IT services and healthcare providers. During the pandemic, she has served as the lead for the implementation of several innovative telehealth services in UCSF, including the emergency department. So with that, I'll pass it on to our guest.
Thank you very much for that lovely introduction. I'll start off the presentation for today, and I'll try to hold my comments down to the time allotted because I like to talk a lot about billing because I love it. A common nomenclature with regard to telehealth is really important so that your stakeholders and your colleagues in your places where you are providing telehealth is understood. You can use these definitions or you can build upon them. I got these definitions off the Medicaid.gov site. They seem the more similar to the definitions I prefer. I don't know if that's the preference at my institution, but these make the most sense to me. So telehealth is all-encompassing, and the practice of telemedicine is where there's an active interaction, synchronous video conference between a patient and a care provider. A store and forward encounter is a transmission of a recorded health history or a picture that would go, these are the definitions from HRSA and seem to be used. Thank you, Soraya. Yeah, thank you. So that would be like if you get a picture of a mole, you send it to your dermatologist and they can respond back to you at a later time, still using the regular evaluation and management CPT codes that we know and love. Remote patient monitoring, also known as remote physiological monitoring. There are two P words used in this acronym quite commonly. Connected electronic tools. So this would be anything that would be a Bluetooth enabled or wireless or even wired transmission of health data that would be transmitted to a provider at a distant site from a patient's home or location. Mobile health is just anything you get on a mobile device. It doesn't have to be pertaining to you in particular. Targeted text about anything. I just got a targeted text myself not 30 minutes ago that is talking to me about COVID testing being available in the streets of San Francisco right now, and to contact go to the URL provided to see where those testing facilities are. So that is what's known as mobile health. These are things that I didn't even speculate about in terms of notifications about disease outbreaks. Like, whoa, what's that? Next slide. And you can see about a month ago, I got the public safety alert for Contra Costa stay-at-home order. I live in San Francisco. I'm not sure how I got signed up for the Contra Costa alerts, but it's good to know what's going on with my friends in far-flung Bay Area locations. And then, of course, here's a pulse oximeter. This one's Bluetooth enabled, but you can certainly distribute these to your patients that are just battery powered, and the patient can monitor themselves and report to you. And here's a Bluetooth enabled blood pressure cuff. Probably very familiar with these, and we're going to talk about how these may or may not be used in your various practices. Next slide. Documentation, this is our favorite. So generally, for your synchronous telemedicine encounters, as a practitioner, a provider who can generally bill an E&M visit like on the ground or in the clinic, you should be familiar with the 95 general guidelines, which are what probably a primary care provider or a general practitioner, nurse practitioner would use for a general medicine practice. And the 1997 are specialty specific E&M guidelines with exam elements that are specific to a particular specialty. There's no reason why a neurologist has to examine someone's nails or an extremity unless they're going to be monitoring something to do with edema. If there's cardiology, some kind of heart medication that might interfere with their neurological medication for a migraine. So these are specific to a specialty so that you can ignore parts of the exam that don't pertain to you. So we've had a lot of discussion with providers about how do I get an 8-point exam for a new patient via telehealth. And so what is interesting is that during this public health emergency that CMS came out with that interim final rule comment that said that during the pandemic, the emergency, we can use the 2021 AMA E&M guidelines. There's no real necessity to bill a history of present illness. There's no necessity of a physical exam. You really just need the medical decision-making made to address the patient's concern at the time of the telehealth encounter, and or the time you spend. So on the right there is, it's going to be included in the PowerPoint you receive from CQC, but these are the common time associated with each of these CPTs that you typically use when you see a patient in clinic for a medical purpose. The AMA guidelines that were first set out to be used as of March 30th had time specifications for total encounter time for the day. So if I see a new patient and I spent 45 to 59 minutes throughout that day prepping for seeing the patient and then maybe ordering follow-up labs and such afterwards, I would say I spent 45 or 47 minutes taking care of this patient today, and this is the medical decision making I made, and these are the tests I'm ordering. It was too confusing for people, so as of April 30th, they just said, let's just go with the time base time elements that we propose or that we're currently following. So if you're going to bill a 99204, you have to at least hit a base level of 45 minutes. And that, again, can be the entire duration of the time you spent taking care of the patient that day. It does not have to be, I spent 45 minutes with the patient, over half of which was spent counseling, coordinating care. It could be, I spent 45 minutes preparing for the patient. I discussed with the patient their medical problem, XYZ, and then afterwards I spent an additional 10 minutes for a total 45 minutes for that day. We haven't had any practices really go to that level yet because it's new and it's perplexing, and we all just love over half of which. I do. All right, next slide, please. This is where you can find the URL for that. And there's slight modifications to the table of risk. It's not that different. Coders, we love the fact that a level 4 usually means that someone has done something with a prescription medicine. They've either titrated it, messed with it, or ordered it. That is a straight out level 4. Next slide. So coding and billing. So you ask questions and we have some answers. For one of the questions, any special rules for billing nutrition visits? So typically nutrition would be an incident 2 in a physician office, a non-facility office, and there are specific codes that you can find on the list of Medicare telehealth services that are specific to nutrition services. So, either you're gonna bill the G codes associated with diet counseling, or you're gonna bill the medical codes in your discussion about that you have with the patient for that day. Annual wellness visits are covered by CMS and other payers. We've had some discussions with commercials about what they're going to reimburse on those, because typically there are things they want included in their definition of an annual wellness visit under their plans. But CMS definitely is including that, and these are the 2 CPT codes associated with it. Follow-up visits, definitely, there are your E&M codes that you would typically use in a clinic. The CR modifier, it's not necessary on any of our telehealth visits because we're using the 95 in most instances for telehealth visits. And is there a requirement to bill one code over another, I think is the question. It's whatever best suits your practice. What is I think for the most part, the payers and CMS want you to do what you're normally doing. So don't try anything too fancy. Don't rush out and buy 10 licenses for Zoom if you need to get up and running. We all know that, oh, look, you can't even see that. FaceTime is an allowed mode of communicating with your patients during the PHE, as is Skype, which seems a little bit less secure to me than an encrypted iPhone. But for folks that don't have it, don't have an iPhone, great, use Skype on their computer. And then during the course of the month, where the rules were released around, you know, you can use Skype, you can use FaceTime, people were unhappy that, gee, there are still people, Luddites like myself, who still have landlines, even though I also have many electronic devices. But many people still just have a landline because that's what's available, and they don't have the bandwidth or any kind of networking capability in their location. So during the last release on April 30th, there were another additional column was added to the list of telehealth services that not only said this is a temporary addition for the public health emergency for COVID-19, the additional code for about audio only is allowable as well. So take a good look at that list. Next slide, please. So the list can be found. There's a list of that can be found on the CMS website, and I'm pretty sure I pasted that somewhere. But if I haven't, I'll definitely forward it to CQC so that they can give that to you. You know your payer mix and the rules for each. I did see a comment that you know, everybody's so particular about what they want and what kind of modifiers. There is variability. So know your payer mix. If you are 75% CMS, great. You know, really just nail down your billing requirements for CMS. And if the other 25% is Medi-Cal, really kind of nail down what you need for Medi-Cal. But as you can see, the link that is also on this slide, really great coverage policies as set out by CCHPCA for California. Really nice. Let's see, Okay, so, and the rules for these things. So billing pre-COVID, the facility-based work review awarded was with the use of place of service 02. And I know I'm talking to a lot of physician-based offices. And so you were getting a lower reimbursement from CMS because the originating site was getting the facility fee. You weren't getting your full work RVU balance from CMS because the patient was not coming into your facility. So both of you could bill, if it was Medi-Cal, the T1014, but the originating site would bill Q3014. So what Medicare now has done is said that, hey, you non-facility based people, you are going to bill the non-facility based code with a modifier 95 in the usual place of service. So they retired us from using 95 because they said it was redundant when they moved to place of service 02. And now they said, well, guess what? We're going to use modifier 95 during the pandemic. And then you're going to use your normal place of service to indicate that we need to pay you at the non-facility rate as opposed to the facility rate. Next slide. My puppy just came and snuggled next to me, which is why my computer's moving. So telephone codes are a really great way to bridge the gaps. There were several questions about how is telehealth making things better for all patients who are afraid to come in to the clinic, as one of the comments said there. So during the PHE, on March 30th, they did release the fact that they were going to pay for telephone calls. And these were valued higher than the G2012 code, which is the virtual check-in. So these were valued higher. They're called telephone E&Ms. So it's kind of the same way you document for the AMA 2021 guideline. You're going to have a chief complaint and how you medically manage the patient during that phone call. You also have to make sure that you hadn't seen the patient about the same thing for the prior 7 days, because we all know that's kind of bundled into the current E&M valuation for an established patient or a new patient. And then that you're not going to see the patient within the next 24 hours. So if it's a problem you can take care of on the phone, you're not going to have them come in the next couple of days or the next day. Also note during the public health emergency, this applies to new or established patients. Also, a lot of people complained in the last month and they said, hey, we want more money for these telephone calls. What about the disparity? What about bridging the gap to people that can't come in and only have a landline? So they did crosswalk the 99441 to a 99212 work RVU. 99442 is crosswalked to a 99213, and a 43 is crosswalked to a 99214. I seem to have frozen. There we go. So virtual E&Ms are also, they went into effect in January. So when you're thinking about long-term here and you want to start implementing something and you're thinking, well, phone calls are going away, why should I even start? Well, maybe you want to start doing a virtual E&M instead if you do have an EHR that you can utilize for this. So again, it's for a new or established patient during the PHE. You can tally the time you spent texting or emailing somehow in a documentation method for up to 7 days. And the first code is for a duration of 5 to 10 minutes. The second code, 11 to 20, and the other one is 21 or more minutes. So this is you getting a message in perhaps my chart from your patient saying, hey, you know what? I felt super funny taking this aspirin and I have a question about whether or not it's interacting with this medication I'm on. And so you would then say, do you want to, you'd email back or text back, do you want to have a medical consultation or an e-visit? And you understand that there's going to be liability associated with it. There's going to be share of cost. Patient says, yeah, I don't want to come into the clinic and I don't want to talk to you. I just want to email you. So they probably don't put that aside on there. But that's how you can get reimbursed for this, and it pays pretty well. Next slide. So here are your modifiers. 95, apply to the services furnished via telehealth. This seems to be par for the course for everybody. The only commercial payer that I know that's deviated from this is maybe, I think it's Cigna, and they'll allow for a GT modifier or a 95. Why even bother? Just use the 95. They still are mentioning that you want to use the G0 if you're a neurostroke provider and you're seeing patients in an ED and you're not going in. The cost sharing, the CS, is for actually usually some kind of service that's going to result in an order for an administration of a COVID test. So maybe the 99213 you bill, or the 99214 you've done via face-to-face. The modifiers do apply to FQs, but there's some really great information that's going to be posted on the CCHP website in follow-up to a webinar I did with them on Tuesday. My co-presenter was the FQ queen, I believe. Okay, so I have a couple of more minutes. Next slide, please. Diagnosis codes. So in terms of qualifying for that 99213 using the CS modifier, I'm going to order a test. So these are the different kinds of ways I would use the CS modifier if I went ahead. So can exposure be assumed? I don't think you can assume exposure unless somebody went into an ED and got directly coughed on, or, there's been some really unfortunate incidents lately that we're all aware of now that, you could assume exposure if someone was on a crowded street corner, no one was wearing a mask and there was lots of coughing. But you really don't know because people are asymptomatic. Codes to apply for services received during and after diagnosis. The following slides will show that. So next slide. So these are the different codes. I won't go into them in detail because I want to leave time for Mira to talk because I'm talking so much. So I have 5 minutes. So yeah, so here's the encounter for screening. Next slide. So this is kind of pre. Here's where someone said, you know what, my neighbor had COVID and they brought me a tureen of soup over and I touched all their stuff. So I suspect I have exposure. So here's the code you would use for that. Next slide. Observation for suspected exposure, but it's ruled out after evaluation. Like, I think I have exposure, and then you have an encounter with a practitioner who says, you know what, just because you walk down the street, just don't even worry about it. But that was the chief complaint, right? Patient came in because they thought they had exposure. So you need to put some kind of code on the encounter for payment. So this will be fine. Next slide. And then here's your positive test result. Next slide. And here are your resources. The 2021 code changes, the Noridian fees associated with all these different codes, the Medicaid FAQs, and really great resources that are available on the CMS site. And then the telehealth codes is where you're going to find that listing that I showed you a brief snippet about that said effective during the PHE, and then also effective during the PHE, and you can also use a telephone. So next slide. And I'm going to pass this on over to Dr. Mira Subash. Thank you.
Thank you, Carol, and the CQC for the opportunity to share some insights from the provider perspective. I will keep my comments brief. I know we want to have some time for questions. So I wanted to share briefly on a case study in the emergency department here at UCSF. I think many of us have found ourselves in a similar situation in adapting quickly as healthcare systems during the pandemic. My goals are briefly just to share with you how it's possible to launch a telehealth program quickly, how to be creative and using what technology you already have in your facilities, and how to start that up. So as an emergency department, we were faced with the challenges of creating a process that had a few goals in mind. One was, how do we create a high throughput process to screen patients for COVID who were presenting in person to the ED, to our containment tents? How do we minimize staff exposure and conserve PPE at the same time? And as we head towards a mode of recovery planning, and we notice that a lot of patients, and you guys have mentioned this in the comments, are reticent to come in person to get care, how do we provide a virtual care alternative that we can still effectively bill and effectively care for our patients? The tools that we used in our ED were iPads, which were repurposed from other parts of the hospital. They were equipped with medical grade cases or single-use screen protectors, and had a video conferencing platform app installed. We use Zoom, but like Carol mentioned, many others have been approved during the PHE. We have all-in-one telehealth carts with remote peripherals attached and disposable single-use headsets for patients to use while they're in the containment tents to interact with providers who are outside the tent or even off campus. And then these workstation on wheels that nurses or folks in the clinic may be using, we repurposed them to be Zoom ready. So there wasn't an additional expenditure at that point to convert into telehealth. Our team included an ED attending. I was an informatics fellow on the project. We worked with IT services, and then with Carol's support, we had support of the Telehealth Resource Center. I saw one of the questions was about capturing vitals remotely, I think that is a great question, probably a webinar to itself, and that there are many new products being approved currently. One that I'll mention is a pilot of a Bluetooth stethoscope for transmitting breath sounds that if a nurse or a patient was able to place the chest piece in the different lung fields, we were able to figure out a way through Zoom to transmit these breath sounds to remote providers so that they could, get at least a high level sense of their pulmonary exam. This technology was also shared with the ICU and the respiratory care practitioners. Our method of communication, things were changing really quickly, but we chose to use tip sheets and train super users who were actually serving in the containment tents outside of our ED. And so with these key ingredients, we were up and running in about 2 weeks, and were able to take advantage of providers who were off campus or furloughed or on home quarantine who still wanted to stay active clinically. So overall, lots of learning from here, but hopefully this gives you a flavor of the problem statements we're facing around implementing a telehealth solution quickly. Next slide, please. All right. And then along with Carol's tips on billing, I want to speak from the provider perspective. I understand there's a lot of providers on the call, so I'd be interested in their opinions as well. But we're asking providers to pivot really quickly to change their entire model of doing an H&P through video visit or telephones. How do we reduce any barriers for adoption of telehealth and really, encourage providers to become more comfortable with this? As a clinician here, I have found that having a documentation checklist, either on paper or electronically at the elbow when I'm doing my clinic appointments, has been really helpful. My clinic has created scripts for how to introduce a video visit to a patient, how to confirm their ID. We've built note templates, which include a telehealth consent statement at the bottom, already automatically filled in so that when coders go back to review documentation, they can very easily view this note as a telehealth or video visit note. For those of you who have EMRs, which allow you to create automated phrases or dot phrases, we've created a few which allow providers to easily plug in how many minutes they've been on the telephone, or how many minutes, per the MDM for 2021, how many minutes the entire encounter has taken. And then I've also found that having a clear workflow communicated to providers when a video visit or a telehealth encounter fails has been incredibly important. And I know each practice is very, very different, but in order to really maximize and optimize billing from one standpoint, but also capture the clinical decision-making that's happening, we've been able to shift to creating a telephone visit note. The documentation continues through into a telephone note, even if the video visit fails. I've also found as a provider that it's really helpful for me to know what are my on-the-ground resources that remain with regards to accessibility for labs, radiology, referrals. What's going to be the paperwork process now if I'm only going into clinic a few times a week as a physician? How am I going to communicate with my staff? So these are the sorts of concepts that I think are really helpful for providers as they pivot toward telehealth. And then, I see that circle graph at the beginning with regards to how many folks are getting feedback on their claims. I think sharing this with doctors, it could be anonymized, but I think it's really helpful to us, because we are trying to pivot quickly and care for our patients, but we want to make sure that we're, coding, we're putting the appropriate elements that are needed, and that we're actually capturing the work that we're doing. And then I'll just leave you with a pro tip. Doximity dialer, and I have no financial interest in this app or company whatsoever, but it's a great way to be able to call from home, and your personal cell number is actually masked, and the phone number of your clinic or hospital will show up on the patient's caller ID. So that's something else you can provide providers just to make this whole transition go a little bit more easily. And with that, I'll turn it back to Carol.
Well, hi. I guess we'll both get questions and answers. I
Yeah.
tried to answer some that are in the chat already.
Yeah, let's move to the QA part of this. We have some questions that we've compiled from when people registered. We can also take some of those that are coming in through the chat now. And I saw Carol answered some in the chat regarding the vital signs and regarding when we'll need to revert to HIPAA compliant platforms, which will be when the public health emergency is declared over. Looks like we have some others that have come in here. Do you have preferred vendors to get electronic monitoring devices, and are any health plans providing these to their members that you know of? From Michelle Duran.
There are remote physiological devices that you just have to make your own decision on.
Mm-hmm.
There are 2 codes that you can submit for the setup and then setting to a specific patient. And the reimbursement for those, that you can bill them incident to in a physician office, and your staff can provide the service because they are staff billing. They're not provider billing codes. And the one pays about, I want to say $170 in San Francisco. Maybe that's a bit high, but that is accounting for your staff time as well as the cost of the device. And then the second code is for the time spent in agreeing upon what kind of reporting that the patient's going to do back to you for the remote physiological monitoring. But really no favored devices. I mean, we had, oh God, what's the name of the stethoscope that we have? We had
Yeah, the Littmann. Yeah,
the
the Littmann.
Littmans, right? Everybody has a Littman, right? And so we have one that is Bluetooth enabled, and you know, it works great if you have your patient in a clinic next to a cart with someone else kind of maybe doing a telepresenting, I would think. We tried it out for our surge COVID tent, and you know, we wanted to keep the cart with the software outside of the tent. And then, so of course the transmission had to go through the tent lining. And so it was a little bit more difficult. And there are peripherals that can be purchased, like from Best Buy. There's Tyto Care, which I haven't laid physical eyes on, but I do know that people love them. And you can get reimbursed from your FSA account for stuff like that too, if your patients have FSA.
Carol, do you remember, we have these pulse oxes also to give to patients. Do you recall the vendor on that one? Because it's another potential peripheral that we were sharing with.
Well, those were just battery operated, and our respiratory clinic was giving those away for people that were coming in to be triaged for COVID. So they were sending people home with pulse oxes. So when their oxygen was decreasing, they could monitor it themselves and then say, hey, you know, I'm at, I don't know, 80%, you know, call 911 for me, or just call 911 yourself. But they were sending folks home with the pulse oxes. I don't think they were used a lot though. I think because we have done so well in the Bay Area that not a whole lot of these were sent home.
Yeah, this was all.
If you have some other questions, you could chat those in or follow the instructions at the bottom of the slide to unmute yourself. Carol, Mira, do you have any other kind of general answers to some of the questions that came in during the registration? I know we kind of, Carol, you want to do the exercise of kind of clumping them together and looking for trends.
Let me bring that up. Let me vamp a little while we're talking here.
There's also a question are telephone visits to be used with 95 and POS 2? I think you did mention that earlier, Carol.
I'm sorry, what was that one? Oh, telephone visits. Okay. So telephone visits themselves, this is a nice distinction between managed Medi-Cal, Medi-Cal, and other payers. So telephone visit codes themselves have no modifier, and they're just regular clinic places of service. Because you should be able to use them in non-COVID times. Hopefully they're not going to take them away from us. Because the G2012 is known as a virtual check-in that can also be billed as a telephone call or just a brief text back and forth via MyChart. It's about $14 reimbursement. So that's place of service, regular clinic. That's going to be POS 11. No modifier needed. Now, right, Soraya, you're correct. So yes, regular place of service. And for what's different about managed Medi-Cal and Medi-Cal is that if you can fulfill the requirements of an E&M visit on that phone call, like a nice comprehensive or maybe detailed history of present illness with a chief complaint, you can document even physical exam over the phone. You can get someone's, if they're oriented ×3, for instance, or if their delivery and speech seems to be like a general comportment of ease or whatever you would say when you're seeing patients face to face in terms of psych or general appearance. So you'd have to put that under psych, it's not general appearance. And then also anything that you would document in your medical decision making for Medi-Cal or managed Medi-Cal. So I think you could really get to a level 4 if you're going to get a nice detailed HPI, and then you're going to talk about someone's meds in your medical decision making, and you change their how they're taking it, or you mess with it somehow. You know, I'm going to move it up 5 milligrams, or I'm going to change you to 1 time a day instead of 2 times a day. As long as you're adjusting something to do with a medication, that is a level 4 right there. Again, as a coder, I love anyone who's messing with meds. It makes it so easy for me. Another way you could get a level 4 with medical decision making is if you say, like, you know, I really need you to go in and have an echo done, and you make that decision there. Now, level 5 is like when you're like, let's talk about your heart transplant, or let's talk about when you're going to come in and get that diverticulitis excised, you know, for a major surgery. So that's usually a level 5, unless you're talking, you know, you can use time-based for these telephone calls too. You know, so if you're talking to a patient for 35 minutes, that's level 5 for follow-up. So why not? Document that time.
Great. We have another question here from registration. Will the MACs automatically be revising denials due to rule changes over the past few months, or do practices have to resubmit?
I was on a revenue call yesterday, and someone said that they were getting revised payments. I think you'd want to call your MAC just to make sure, but I do know that they don't want to get duplicate claims, and they don't want to pay you and then get a charge correction, because then they're going to deny that with a duplicate claim. I think what they want to do is fix it themselves, and everything's retroactive back to March 1st anyway. So as long as you had put the right modifier on there, and you go back through your claims and you're like, oh, well, I submitted that to Medicare as a facility, like I'm a physician office and I submitted that as a 99213 with place of service 02 to CMS. What I would want to do is go ahead and do a charge correction on that and submit it with the 99213 with a 95 place of service 11. So you get the full non-facility work RVU allocation.
Great, thank you. Do we have any other questions from the participants, either through chat or you want to speak, you can unmute yourself. Okay.
We
well,
answered it all. We're amazing.
excellent. Well, we're approaching the top of the hour. Why don't we move to the next slide, please? So we, CQC would like to encourage practices participating to participate in the primary care collaborative survey that's done nationally to help measure the impact of the crisis on primary care. These poll results are being used by advocacy organizations across the country to advocate for primary care support during the crisis and afterwards. So if you have time, please take the survey. Next slide, please. We'd like to close with one final poll just regarding how helpful this webinar has been to you. While you're filling that out, I'd just like to first thank our speakers and attendees. It's been a very informational webinar from our perspective, and so thank you very much. If you have questions following this, please let us know, and we can certainly try and track down the answers for you. Please join us for our next CQC webinar, which will be on May 29th from noon until 1 p.m. on patient engagement and virtual care. And you can also access CQC's COVID-19 resource page, which is updated at least weekly, which includes resources for providers like telehealth implementation billing. Michael from the CQC will put both links into the chat. Thank you very much, everyone.
Thank you.
Thank you.